Well, good afternoon, colleagues, and good afternoon to those joining online. It's an absolute pleasure to welcome you to this lecture by Dr. Ngassa Piotie. Patrick is a medical doctor who is based at the University of Pretoria, but his substantive role is as a chair of the Diabetes Alliance. And at the end of last year, the Diabetes Alliance hosted a 3-day meeting in Johannesburg where they launched the Johannesburg Declaration, which highlights the concerning crisis that our country finds ourselves in, with diabetes being one of the major causes of both morbidity and mortality. And in this declaration, they call upon government to support a whole of government and whole of society response with specific deliverables that can be undertaken by the President, the Minister of Finance, the Minister of Health, Parliament, and of course, the premier science council in the country, the SAMRC. So it's an absolute delight to have Patrick join us today and to engage with us around areas where the national leadership around diabetes care and scholarship in the country. So Patrick, welcome, and we very much look forward to your remarks.
Thank you. Thank you very much, Prof. Tusi, for the generous invitation and the warm welcome. I would like to thank everybody in the room. Thank you, colleagues, as well as the colleagues online. Indeed, I'm Dr. Patrick Ngassa Piotie, and it's a pleasure for me to be here today representing the Diabetes Alliance and ending to be the voice of the millions of South Africans living with diabetes, but I endeavor to do justice to their needs and to their voices and to their aspirations. Thank you very much for the opportunity. I've prepared a few slides. I hope I find my way around it. I'm not able to share.
What happened to GT?
He's trying to sort it out so that we can activate the share button.
Oh, so it's not my fault. Okay.
So for the colleagues online, we're just trying to upload the presentation, and we should be able to start momentarily.
I'll use the opportunity, Prof, with your permission, to say a few words about the Diabetes Alliance. The Diabetes Alliance is a non-profit organization that was started in around 2019 by Bridget McNulty, a person living with type 1 diabetes. The spirit behind the Diabetes Alliance was really to create an organization that could represent the people living with diabetes in South Africa, knowing that at the time already we could see the sign of a disease that was on the rise in terms of prevalence and incidence. And obviously, there didn't seem to be a national conversation around diabetes. So I joined personally the organization around 2020 and subsequently was nominated to become the chairperson. One of the big initiatives that we started, as you rightly mentioned, Prof, the Diabetes Summit. We found that in South Africa, there were no platform where people could come together and talk about diabetes in South Africa. We have some societies, for example, the Society of Endocrinology, Metabolism and Diabetes in South Africa, SAMRC. They have a congress, but it's mostly scientific, where the voices there are mostly clinicians, endocrinologists, with little space for lived experience and for even a public health approach. So we started the summit in 2021. It was a 4-hour event. Obviously, again, post-COVID, we all know how COVID revealed, in quotes, the vulnerabilities of certain member of our communities, especially those who were living with diabetes. And we had therefore that meeting, and we found it to be a success, and we agreed that we will have it every second year. The next edition was in 2021, when we moved virtually to have a full day event at Future Africa campus in Pretoria. Again, we were happy with the outcome, but we found that one day was too small. We were rushing through the discussions. What we try to achieve with the Diabetes Summit is really to talk. What are the solutions? What can we do about it? It's not a standard format of presentation of scientific publications. Is mostly about panel discussions and engagement around the various stakeholders. So last year, we managed to have a 3-day event with a rich program where we had some partner organizations that could run workshops, but we also had the panel discussions around, for example, education, management and access to care, surveillance, research and innovation, and prevention and awareness. We obviously were grateful to receive the support from the South African Medical Research Council, but by also other bodies like the World Diabetes Foundation, WHO South Africa, and a strong presence of the National Department of Health. And besides that, there were about 20 partner organizations, some of them which core business is diabetes, but others were related. For example, the Healthy Living Alliance, HILA, normally they are mostly in the food space, advocacy space, but is very much connected to diabetes. So some of those partner organizations were part of the event, and it all turned out to be quite a success. Yeah, I'm trying on this one. I don't see the presentation.
Just
So yeah, that's the background of the Diabetes Alliance, and we are happy to be here this morning to talk more about the Johannesburg Declaration. Indeed, it's one of the outputs of the Diabetes Summit. It's a call to action, and we'll be telling you a bit more about it. This is working. So that's me. Besides occupying the role as chairperson of the Diabetes Alliance, I've also been recently nominated or elected as the chair of the Kofi Annan Fellowship Alumni Executive Committee. That's something that I'm quite excited about because of my passion for the African continent. I would like to start with this quote that I've used previously. It came out in the Lancet in 2023, and it says that diabetes will be a defining disease of this century. How the health community, and I might add the research community, deals with diabetes in the next 2 decades will shape population health and life expectancy for the next 80 years. It's really a profound quote, and I like to really go back to it, because in some ways, where we found ourselves today, it's similar to where we were with HIV in the late 80s, early 90s, whereby the epidemic was started to bloom, and we were still not knowing what to do, which direction should we take. I think it's really this type of moment that we are where we are sitting with diabetes in not only in South Africa, but also in Africa and globally. But one thing that I thought about when I was preparing this slide is that crises create opportunities. It's all depend on how you want to approach it. So during the course of this presentation, yes, we will be highlighting why diabetes is a crisis, why we say that diabetes is a crisis in South Africa, but what are the opportunities that are behind that crisis, especially for the research community and for an organization like the SAMRC. First thing first, we need to accept and understand that it's a Pan-African challenge. It's all around Africa. But the importance of it is that SAMRC therefore has the potential to become an African leader when it comes to diabetes research. And obviously, we are talking about a continent of about 1.5 billion people. So this is really not a small matter. Why is it so prevalent in Africa, or why is there that rising prevalence in Africa? Is because of rapid urbanization. Our people are moving away from rural areas, flocking in urban centers, in fact, looking for economic opportunities. It's about changing food environments, and a lot can be said about it, how unfortunately, a lot of our farmers are not able to compete with the food that come all the way from Brazil or from America or from China. Therefore, most African countries import 80% of the food that they consume. I saw some experts saying that actually 85% of the food consumed in Africa is imported. Meanwhile, we have most arable lands. As I said, we don't want to start a whole talk about food environment, but it's very critical, whereby you find that our staple food has become rice and pasta. Meanwhile, they are not indigenous from the continent, and that leads to other problems. We have an aging population. More and more, we are able to control infectious diseases, and our people are living longer, even those who are infected with conditions like HIV and others, but still we are now faced with other challenges. We have talked about the epidemiological transition, whereby most African countries, South Africa definitely, places like in the north, and Rwanda and others have passed that turning point where people are dying more from non-communicable diseases than from infectious diseases. And we have what we can describe as a weak health systems, but there are legacy issues there. Initially, our health system was mostly designed to respond to infectious diseases. There's a colonial past where the priority at the time was to protect not only the colonizers, but also the indigenous population that were used in labor. So because of that, the design or the mindset in how our health system were designed was infectious diseases. Therefore, these are some of the things that we need to be aware, cognizant of. In the next slide, I will just present some of the numbers. These were taken from publications that have just recently been released from the Lancet. There have been a number of reviews that they've done in the past couple of months, looking again at the situation of diabetes in South Africa. What we can say here, for example, there are some alarming numbers. The fact that by 2050, the number of cases would have increased by 142%. Another worrying number is the fact that 73% of people with diabetes are undiagnosed. And obviously, the big challenge of gestational diabetes that is not talked about enough, whereby initially, even when I was studying medicine, it was said, no, the lady during the pregnancy, there's glucose levels are high, but then after she delivers, it goes back to normal, everything is fine. But now research have demonstrated that those women who have had gestational diabetes are at higher risk of having type 2 diabetes in the future. And the children as well, who were a product of those pregnancies, are also at increased risk to develop type 2 diabetes. Therefore, it's something that we need to look closely. There are some details, informations about the fact that obviously all this is happening while there are still quite a number of infectious diseases, tuberculosis, HIV, malaria, that we are still grappling with. The critical issue of data is a major problem on the continent and also in South Africa, as we will discuss later on. The second point to highlight and the specificity of diabetes in sub-Saharan Africa is the complications. Unfortunately, we are not doing well when it comes to preventing those complications, meaning to ensuring that people with diabetes are living well, are living longer because of poor management, because of those multifactorial issues. There's high rates of complication, whether you are talking about diabetic nephropathy, whether you're talking about stroke or peripheral neuropathy. Amputation is the #1 complication in sub-Saharan Africa and also in South Africa when it comes to diabetes. Meanwhile, when you go to other places, you don't see the same patterns. So these are issues that we need to be confronting. The policy and financial gaps of South Africa, at least with the primary care system that we have here, people can, to a certain extent, access care without having to pay anything. But in other countries, even people with type 1 diabetes, they have to pay out of their own pocket to have insulin. We've heard stories where sometimes in a family, parents have to decide whether they should buy insulin or buy food for the family. And obviously, that leads to a number of challenges. Zooming therefore into the South African diabetes crisis, as we want to describe it, diabetes is now based, according to Stat SA, the leading cause of death. In 2022 alone, there were over 32,000 people living with diabetes that unfortunately lost their life because of the condition. In terms of the prevalence, we don't really have the accurate or the definite numbers. We used to rely on IGF, the International Diabetes Federation, that will release the diabetes atlas every other year. But when you look at the findings or the estimates in the previous atlas compared to the one in the current atlas, the current edition, the numbers almost were cut by half. We are asking ourselves what happened to all those millions of people who are now not more counted as living with diabetes in South Africa. Can we still rely on those numbers? But obviously that is also an opportunity for us to say we need to have better data. Those people who are in business or management say, if you cannot count it, you cannot manage it. Therefore, which direction are we taking if we don't even know how many people we are talking about? What is the burden that we are faced with? We know definitely that there are increasing complications, whether through concessional studies or anecdotal findings. With the Diabetes Alliance, we sometimes receive emails through our website, either from healthcare providers or from people living with diabetes themselves. There's one email from a healthcare provider where they say, we perform too much amputation, and that was it. They just say, we need help. So it's to that level, and it's really alarming. And obviously, in diabetes, once we are having complications, there's a tremendous impact in the quality of life. The often could be the breadwinner in the family being amputated or having to go through dialysis. That really complicates everything. We heard, for example, that here in the Western Cape, if you are 40 years or above and living with type 2 diabetes in need of dialysis, they don't even put you in the waiting list. That's the cut. The cut age is 40, and that's really, that cannot be. That cannot just that shouldn't be, and it's really a big problem that we are dealing with. But we didn't reach arrive there overnight. It's been a slow progression. This is also findings from Statistics South Africa, tracking the number of people living with, or dying, should I say, number of deaths from diabetes from 2008 to 2018. And you can see that the trend is really on the up and up. And this is confirmed by this other publication that they put out in 2023, where they were saying that the number of deaths by diabetes had doubled between 1997 and 2018. And we wrote an opinion piece about it, just trying to raise the alarm. But indeed, we do have a problem. This could be under estimations. As we know, StatSA is not a perfect system to estimate, to track death based on death certificate, but that's the next best available data that we have, and already is showing that we are dealing with serious problems. And if nothing is done, obviously the trend will keep going on the rise. We do have a policy instrument. It's called the National Strategic Plan for the Prevention and Control of Non-Communicable Diseases. It was released in 2022. And for the first time in South Africa, we were given by the National Department of Health some targets that apply for diabetes and hypertension. And as you can see on the slide, the targets say that 90%, the goal is to find or to diagnose diabetes in 90% of the people above 18 years old who could be living with either diabetes or hypertension, ensuring that 60% of them is receiving an intervention, and 50% of those receiving an intervention are, in quote, controlled. This is obviously from the learnings of the 1990s that some of you might be familiar with, the target that were applied with the HIV, and some have said that it's a bit why 90, 160, 150, why not to be more ambitious? But yeah, that was what the Department of Health was happy to stand on. Unfortunately, at the time of the launch of this document, we were already talking about the fact that we were starting with targets without even having baseline. So how do we then track progress when you don't even have baseline to start with? Again, yes, a welcome policy instrument, but that also highlights strong failures. So all in all, we can see that we have a problem. For anyhow you look at it, people in communities are suffering, they are losing hope, people are being amputated. We have a health system that is not necessarily delivering the goods. We have policy instruments that are themselves not necessarily perfect. Therefore, there's a crisis, but there's a number of opportunities. The first one that we're going to highlight is the leadership opportunity that presents itself. And civil society indeed took the lead, and through this document, the Johannesburg Declaration, which, as we mentioned, is a joint effort between 24 civil society organizations, people with diabetes represented, researchers, health professionals, and the whole lot have said diabetes deserves a specific focus. We need accelerated action, we need leadership, but we need also accountability, and we need to achieve equity, because it cannot be that people living with diabetes who have access to resources should have better outcome. Meanwhile, 85% of them who are getting access to care through the public healthcare system shouldn't have access to the best available care. We cannot allow to have a South Africa where diabetes is about having and not having resources. We need to achieve equity. So the document is really a unified call for urgent national action on diabetes. We want the president to recognize diabetes as a public health crisis and to lead the response right from his office, because as we can discuss all day long, the complexity of diabetes require a role of government approach, whereby it's not just the Department of Health, but it's also Treasury, it's social development, it's all those other people, education and urban planning and all that. It's only the presidency that has the power to bring those people around the table and lead a response similar to the what we've seen decades ago when we were responding to HIV. But without such a response, we are very concerned that we will keep achieving the same outcome, which is, as we already saw with the numbers, not very good. So this document is really evidence-based, is people-centered, and is focusing on accountability. I mentioned that there's about 25 organizations that are signatory to the 25 that are signatory to the declaration, and you have them here on the slide. Very various, from Public Health Association to the Retina South Africa, to Novotech, Black Sash. It's really about everybody in the spectrum. So zooming in closely, indeed, the SAMRC is a critical organization in this whole process because a lot of it starts with research. A lot of what we can do will start with research, whether it's to track progress, whether it's to bring in innovation, whether it's to actually change, as we will see in some of the slides, the way we are dealing and preventing or even managing diabetes. So in the declaration, you will see that there are a specific ask, a call to action from the MRC. And here we can just say quickly, it's around diabetes research agenda, innovation, surveillance, as I mentioned, how can we track this epidemic better? Implementation science, that is critical because there's such a gap between the policies that we have and impact in the community, in the life of people with diabetes. We need to involve community more in our response and ensure that our research translates into policy and translates into real impact. Therefore, there's another strong opportunity here is to build what I call national assets. First on the list is, as I was discussing with Konftusi, we need to have a national diabetes research agenda. We need to know what is our roadmap, what are we trying to achieve, is some sort of a compass for the next decade, so that whoever is in the country, we complain that we have limited resources, but we tend to use them without being a concerted effort. Let's have a national diabetes research agenda that bring focus to what are the priorities. Where should the academic institution be focusing on? Where should the funders be putting their money towards? What should government be prioritizing? Obviously, putting together such an agenda require consultation, not only from government, the provincial department of health, the clinicians on the ground, but also the researchers, the academics, public health specialists, physiologists, everybody. Not only we need to respond to today, but we should always keep an eye on what is coming. For example, AI in diabetes. What are the opportunities there? And we will talk about it in a future slide. So really, the first point should be for us to build this national research agenda, and obviously it can be a living document whereby we reassess after 5 or 10 years and we see how it evolves. The second strong asset that we need is a national diabetes registry. We need to be able to understand our disease burden, to track the progression, to what that will obviously improve planning, because when it comes to diabetes, as we will discuss in future slides, there are difficult decisions that the Department of Health has to take. There's been many innovations in terms of new drugs, new technologies, but then they are stuck because they don't know what is the cost implication of integrating those drugs or those products. The assumption is that it's very expensive, but because we are failing to track the numbers, we don't know how much we are necessarily spending on complications, on amputations and all those things. We are not able to make those decisions easy. So if we have a strong diabetes registry, there are very much successful examples all over the world. We can learn from it, and South Africa can lead and show the way for the other African countries in terms of improving diabetes surveillance. The proposal could be to have sub-registries, because obviously we are using the word diabetes, but it's such a complex condition where type 1, for example, has nothing to do with type 2 diabetes. And then we spoke of the challenges of gestational diabetes. So there could be those sub-registries focusing on the subtypes. And obviously that will be used, for example, in the case of the gestational registry on gestational diabetes, or on with the ladies or the women who have had gestational diabetes, we can follow them up as a type of cohort, but also have specific interventions so that they don't convert from gestational diabetes to type 2 diabetes. As it is now, we don't necessarily know where they are. Once they are released from the facility, they are lost in the communities. There are some pockets of intervention. I know Prof. Sumaya Adam in Pretoria is working towards putting things in place to be able to follow those ladies after they are discharged. But for the most part, all over the country, they will be going home and only come back maybe if unfortunately they develop diabetes. I would like to say a few words about this opportunity. It's a research effort that was initiated almost 5 years ago now between a number of role players, not only from the University of Pretoria, but also Wits University, UCT, Stellenbosch, UKZN, and others. From what I've learned before I got involved myself, is that for the longest time among endocrinologists in the SAMRC family, the society, there's been that desire to start a type 1 diabetes registry, but it has never taken off the ground. If about 5 years ago, the effort was again revisited, we received some support from Life for a Child program of Diabetes Australia. A few people came together and we decided to start what we call the National South African Type 1 Diabetes Burden Study. We used two models to collect the data: a direct to participants, where anybody can scan a QR code or click on a link and volunteer their data, but also sending out people in facilities, especially our main centers, because we know that type 1 diabetes can only be found in some centers, not necessarily all over the primary healthcare system. So far, we've collected about 1,700 individuals. The foundation is established. The goal was that this becomes like the baseline, and the next step should be to then establish the registry. Unfortunately, we are at a moment where the funding is running out. Therefore, we have to ask the question, what do we do with this momentum that has been created? What do we do with this goodwill from those organizations and entities? Do we let it go to waste once more, or do we see how we can together strengthen the effort and maybe continue with it? So that really is one of the pressing opportunities that can be presenting itself when it comes to diabetes surveillance in South Africa. The next big opportunity is the NHLS HbA1c dashboard. Some of you guys might not have heard about it. The press release came out sometimes last month. I had the pleasure to visit them and to have a live demo. This is a game changer when it comes to diabetes in South Africa. For the longest time, we couldn't have access to this kind of data. For those who might not know, the NHLS receive HbA1c tests from almost all the country. They will run those tests and they will send the results back to the clinicians. But there were no platform where you could see, even as a facility manager, how am I doing when it comes to HbA1c? Do I have high-risk patients? Do I have patient that I could prioritize on? Now with this dashboard, we have access to not only national data, but also provincial, district, sub-district, all the way down to facility. Meaning if a clinician is trained and capacitated, they should be able to access the dashboard and identify directly from the dashboard who are those patients that are not doing well. And they have access to the patient file. They can even put in place interventions to call them back. For those who have worked in the HIV space, we used to have those interventions, for example, to track loss, to follow up, where community health worker will be deployed in communities to identify those people. When the COVID-19 came and it became clear that people living with diabetes were at high risk, except in the Western Cape, there were no tool that could allow us to go and find those high-risk patients. Now with this dashboard, it's something that we can do. And as I was looking at this data, something clear appears. You can see here, there's a number that is now highlighted, 431,000 I'm becoming like somebody. Almost 500,000. Let me be safe and say that we have almost 500,000 people who were marked as HbA1c above 9% in 2025. Both will see and understand that this is very serious. This is 500,000 of people at risk of complications. Unfortunately, this doesn't give us the breakdown for how many of them are above 10%. But this reminds me when with Provieda, we had the type 1, the swanning insulin project that we implemented. It was quite frequent to see people with HbA1c 10% and above. The drama is that they were like unseen. Unless you have an initiative to go in the facility to look for those files and to collect those HbA1c, nobody is paying attention to that. As a result, we will see, but this patient, this is like the third HbA1c where they're already above 10%. Treatment and change. Treatment completely unchanged. So they really come to the facility and we take their hands and take them through the journey to the complication, the diabetes complications. This was really a big problem. So when we look at this number, obviously we need to go in there and break it down, but it's already a big sign that something not good is happening. And normally, for those who are not familiar with HbA1c, internationally the cutoff line for HbA1c is 7%. Some places in the country we shifted it to 8% because we realized that if we were to say 7%, the number of people that we will be dealing with will be too much. I spoke to somebody from Gauteng this week. They say in Gauteng they decided that we need to go back to 7%. We cannot have this thing where we are pretending that 8% is the cutoff and then people are developing complications. So if you look and you want to add the number from the second column here, you see about 270,000 people. So we have almost 750,000 people with HbA1c not meeting the targets. What is going on there? What was the previous HbA1c? Yes, HbA1c can change because it's a test that normally you repeat every 3 months when you have high values. But it's already showing us the potential for this dashboard, whereby not only researchers but also health managers can be taking advantage of it. So therefore, indeed, for the first time, we have near real-time monitoring because the NHLS is updating the data all the time. As I mentioned, national, provincial, district visibility, facility level insight, identification of high-risk patients, and early intervention. But as we said, having a dashboard doesn't necessarily lead to better outcome. It's the action that comes from the dashboard. Therefore, there's another opportunity here for first, we suggested that, and we are discussing with the NHLS about a national Know Your HbA1c campaign. When we did a survey in 2019 with the University of Pretoria, we had a simple question among the others. Do you know what HbA1c is? 99% of the respondents, people living with diabetes, but some of them with duration of disease 5-10 years, they didn't know what HbA1c is. Even among healthcare professionals, when you see the HbA1c thing output that NHLS sent, there's maybe 2 or 3 numbers there. It was often that we found healthcare professionals that were mistaken, which was actually the actual number that they were supposed to use. So this is the type of problem that we are dealing with. HbA1c is the #1 marker when it comes to glycemic glucose management with people with diabetes. We need to do what we've done, for example, with HIV, where everybody knows what viral load is. Everybody knows what CD4 count is. Because one of the problems that we can talk about, again, for the whole day, is the fact that people with diabetes are very much disempowered. When they go to the clinic, they don't know what the doctor is trying to achieve. They don't know what the nurse is trying to achieve. For the most part, they just receive negative feedback. They are being body shamed often. They are being stigmatized often. And eventually they go home. Nothing is changing. Nothing is progressing. Having this Know Your HbA1c campaign, ensuring that all over the country, at least people with diabetes know what HbA1c is, they know what the number means, but also the healthcare provider should know what the number means and what action they should take when the numbers are not following or are not within the targets, that the desired targets. So that is another opportunity that it presents itself to us. Then we want to move to what we describe as the opportunity to transform care. Just briefly, in South Africa, in the public sector, when we're managing type 2 diabetes, we follow what is called a stepwise approach. First step is lifestyle modification plus metformin. Second step, you add another drug called sulfonylurea, is glimepiride. The last step or third step is when you introduce insulin. That stepwise approach that I describe as a one-size-fits-all approach is completely outdated in other parts of the world. That basket of products that we are using, there's been so many. I like a slide that Professor Zahid Bayat usually use when he's presenting as an endocrinologist working in Johannesburg. He will show on the one side the products that are available in the public sector. It's about 6-7 of them to manage diabetes. And on the other side, he put what is available in the private sector. It's about 60. That inequity cannot be justifiable just to say those products are expensive. The question for us here as researchers is, how can we introduce those products? There's an effort, for example, where the SAMRC is supporting the National Department of Health with something like health technology assessment. There are many processes. How can we fast track those processes? The evidence is already there from those products having been used elsewhere. Why do we always have to reinvent the wheel? So here in this graph, you can see on the other side what we call an outdated model of care, and on the right side, what we should be aspiring to. One size fits all between personalized precision care, reactive care between against prevention first care, glucose-centered management against person-centered management. Here we are mostly managing complication instead of preventing them. And you can go down the list, the challenge with the handful of therapeutic option against the basket of therapeutic option. The fact that mental health in diabetes, which is when you speak to a person living with diabetes, a big aspect of living with diabetes. In the public sector, nobody is talking about it. They go in and out of the facility, they never receive support for their mental health. Meanwhile, there's many people with diabetes who have checked out of their care because of the mental pressure, because of the burnout, because of the anxiety and depression, and our system is not introducing it. I know there are a few researchers, even at the SAMRC, who are also looking at that aspect of integrating mental health in diabetes care. We need to come quickly to some sort of a model that can make those millions of people to start benefiting. And that in itself will also feed into seeing better health outcome. So those are some of the critical points. And each of those lines are really opportunities for research, because often we have the guidelines, but we fail to implement those guidelines. And it's through implementation science that we can find modes and model of care to really start responding to those challenges. Here, one might say, but where is the money where will the money come from to do all those issues that we are saying we should be doing? Already, this is a study that was published some years ago. We are spending, it is estimated that by 2030, we'll be spending about 35 billion rands in diabetes. The total cost of diabetes in South Africa. And they broke down that 40% of that is spent on 49% of that is spent on complication. Therefore, if we manage diabetes better, we can save most of what we are spending now. And instead of spending 35 billion of rent, most of it in complication, we need to be intentional about investing that money to improve the care so that we can have a better outcome in the future. So that's really what this slide is talking about. But I also wanted to highlight the fact that when we talk about diabetes, we are talking about commercial determinant of health. We need to be very cognizant of the fact that there is big food out there with billions for marketing, billions for pushing their products. It's not just that, it's not some of the things that we do. We used to describe diabetes as a lifestyle disease. It's a description that personally I want to move away from, because a lot of the decisions that people take on the daily basis are sometimes not really within the power. They are so disempowered, and often because of economic challenges, the options that are most affordable to them are those poor options. So already even that in itself, similar to in tobacco control, where there is a whole monitoring of the tobacco industry, there should be specific research looking into these practices and looking into those things that those big businesses are doing that is driving the disease the levels that we are seeing. One might say prevention is easy. You should just eat healthy and exercise. But do we really have the formula to prevent diabetes as a country? It's an individual responsibility, but also as a national level. What are those measures that we can find that make those decisions easier for our people? And that in itself will require research. How can we make sure that people are eating better? How can we make sure that people are exercising? If we are not, that will bring urban planning. That will bring in even architecture. Are we building our cities in a way that promotes healthy living? These are some of the questions that we should be asking ourselves with obviously a long-term view. We'll then move to the opportunity to innovate and to drive equity. Here we can talk about AI. This busy slide was just made from a paper that was recently published in terms of what are the opportunities and challenges and future direction in AI for primary diabetes care in low and middle income countries. Some of the, we spoke for personalized self-management, risk prediction and stratification. I presented earlier the NHS HbA1c dashboard. Can we imagine the potential of adding an AI component or whatever? I don't know how to describe it, but what if those data were going through some sort of AI model and picking up those high-risk patients quickly, picking up those areas where we need to invest more resources? The potential is really enormous. But for us to reach there, we need to start investing in that kind of research today, so that we, again, in Africa and in South Africa, are not just becoming recipients, because others are doing that already, and then they will come and propose those solutions to us. As we can see, when it comes to challenges, the issues of equity, inclusivity, the fact that a lot of the AI models are actually trained in population that are not looking like you and I. That is therefore where an organization like SAMRC can take leadership. We should be putting out bursary, scholarship. I don't know what we should use, but our students should be looking into it. Our academic institutions should be really looking into those kind of things. I can mention when it comes to innovation in diabetes at the moment, one of the big revolution in terms of monitoring has been the introduction of continuous glucose monitoring or CGMs. At the moment, very expensive, but a lot of those products being imported either from Europe, US, or from India. What is Africa doing on that front? Are we going to still wait to be recipient of that, or should we start developing those ourselves? And it has obviously a big opportunity in terms of return of investment. We have the biggest population, and if we manage to develop this product for Africa, therefore there's definitely an incentive there. But nobody from outside will come and do it for us if we don't do it for ourselves. So quickly wanting to mention the fact that obviously we need a specific focus with communities. In my work as chairperson of the Diabetes Alliance, having spent a lot of time with people living with diabetes, they provide understanding of the condition that myself as a researcher, I never had until I started to interact with them. But again, this is not new, because when it came to HIV, community-led research played a big role in us reaching where we are. So it's important that we look at that as itself a pillar of whatever we are trying to build, because there is so much wealth of knowledge and so much opportunities that lies within our communities of people living with diabetes. So it's important that we tap into it and we find ways to not only work with the community as a partner in research, but there's issues of citizen science, patient-reported outcomes, community-led monitoring. We are failing to see where are those gaps in our health systems that we should be addressing. Having communities monitoring care themselves. It was done with, for example, the Retize intervention in the HIV space. We will definitely gain a lot of insight and therefore lead to even better research output. Almost closing, this crisis presents itself also with an opportunity for accountability. For the longest time, when it came to responding to diabetes, we haven't made our voices loud enough because of lack of tools like monitoring tools, like registries, like the dashboard that wasn't there. A lot of the gaps were present, were not necessarily seen or revealed to us. You needed, for example, when you wanted to do a study in diabetes, to deploy people in the clinic, to go through one file after the other, since we are still having this paper-based filing system in the clinic. It's very cumbersome, and there's always been a bit of complacence in the space of NCDs in general and diabetes in particular. So therefore, with the Johannesburg Declaration, having diabetes declares a crisis, we need to hold not only ourselves accountable, but also the powers that be and each other accountable. Therefore, there is a proposal that with the African Alliance, we are working on to build some sort of a civil society-led diabetes accountability and action platform that will be supported by the SAMRC if the proposal is accepted, and obviously government, universities, and other partners. The goal really is in terms of tracking commitments, generate community evidence, and also accelerate action. We will be talking about things like specific working groups when it comes to the call to action to presidency, parliament, and the other bodies, because a declaration is only a document if effort is put towards us meeting or working towards the call to actions. Therefore, we need to be tracking the progress with public reporting, scorecards, and the like. That's really what we are highlighting in this slide. This is just a graph showing a bit that ecosystem where there should be at least monthly or quarterly reporting on progress, because if it's a crisis, we need to act as such. We need to keep our foot on the pedal so that we can come back at the end of the year, next year, to say this is what has been achieved. These are the gaps. This is how we can correct and continue to move forward. So in closing, a crisis can also be a legacy moment. And I would like to just share this few words that I'm going to read. South Africa stands at a crossroads. Diabetes is now the leading cause of death, yet this crisis also presents a once-in-a-generation opportunity to transform how we prevent, diagnose, treat, and live with diabetes. Beyond this crisis lies a leadership opportunity, a legacy moment. It is our duty to act for South Africa. It is our calling to inspire Africa. As we're looking ahead to 2027, we are already announcing the next summit, and obviously you are all invited. Because the NSP that I presented earlier would have run its course, it was 2022 to 2027, is therefore an accountability opportunity where we have the team diabetes targets 5 years later, measuring progress and accelerating action. We have some proposed date for now, but obviously more information will be communicated in due course. On that note, I would like to thank you for your attention and opening myself to questions.
Thank you very much, Patrick, for that most inspiring lecture and call to action. You sort of outlined in your closing slide how you think the SAMRC and the Diabetes Alliance can collaborate together around diabetes online. And in this room, we've got scientists from the SAMRC. I wonder if you want to just say a little bit more about more pragmatic considerations around that collaboration.
Mm-hmm. So thank you very much, Prof. Indeed, there are a number of opportunities depending on the field that each can be involved in. But I believe really on setting the tone and having a leadership platform whereby Diabetes Alliance, obviously with its convening power, with the capacity to mobilize grassroots. We mentioned of the importance of community-led research involving people with diabetes in what we do. SAMRC, obviously with its positioning in terms of the leading research organization in the country and the army of scientists in the country. I believe that the successful collaboration will be where together we inform what should be our next step. For example, in terms of having a clear roadmap under the form of a diabetes research agenda. In parallel, because of the need for us to track progress and to monitor actions, especially coming from this Johannesburg declaration, that's why there's that clear format or platform whereby the community is empowered to be able to monitor progress and to hold institutions accountable using obviously research methods and which obviously sits with the MRC, but also there's a need for funding, as you will suspect. So those are the type of conversations that needs to take place so that we can meet the goals that we are setting for ourselves.
You might just stopping sharing so that if there are questions online, we can see the hands. Let's see if there are any other comments or questions in the room.
I'll make a comment. I thought that was fantastic, and I've worked on diabetes now for 20 years, and as you I suppose everyone's in their own little box doing their own little thing. So I think bringing everything together and discussing the roadmap where it's all aligned and you can have a greater impact is incredible. So I would definitely be keen to be involved.
Thank you.
It is an opportunity.
Go ahead.
Well, I have this naive question, like in terms of registry, how can it be coordinated so that researchers, like for example, like Julia said, she has been researching diabetes for 20 years, like some of those data that are required for the registry, how can it be coordinated so that some of those data that is required is deposited in the registry?
Yes, that's a good question. We had, as I mentioned, the workshop at the summit last year, and we had invited Dr. Masvita. For those who might not know, Dr. Masvita is leading the cancer registry at the NICD, and she really engages and share the experience from that front. So the registry obviously will depend on his data sources and the infrastructure. Those are the type of questions that we can discuss. There's some recommendation in terms of the basic indicators that should be part of the registry, but we need to discuss and find what is feasible in our context. Where can we start? And obviously, there's a lot of governance questions that arise. Where will the registry sit? How would access to the data be? What will be the incentive for whoever is feeding the information into the registry? And unfortunately, there's a bit of a fragmentation whereby our clinical data are paper-based at the clinic. Yes, the NHLS is almost fully digital, but then there's hospital data. There's a fragmentation of those databases and data sources. I attended the event at the NHLS in the beginning of the year where they were indeed talking about bringing some of those data sources together. That could be a project that is led from the SAMRC side. We've heard some partners in terms of what should be the basic indicators that we want to see. Where do we start and how, so that we can grow rather than to be too ambitious in the beginning and then not succeed. And obviously put in place a strong governance system so that any researchers in the country who wish to access the data knows what to do to also access the anonymized data.
We've got two questions online. One from Kathy Khan, another from Nita Mora. Kathy, please go ahead.
Thanks very much, Ntobeko. Thank you for a really wonderful presentation that I thoroughly enjoyed. I'm from the Wits School of Public Health and one of the extramural units of the SAMRC, the one in rural health transitions. And I just wanted to mention a research asset, because one of your slides focused on research assets. That is one of South Africa's national research infrastructures that is now firmly embedded within the SAMRC. And that is the South African Population Research Infrastructure Network, known as SAPRIN. There are 7 nodes that are population-based research platforms with fully harmonized health and socio-demographic surveillance systems. They exist now in 6 provinces. There are 4 rural ones and 3 urban ones, and they are longitudinal research infrastructures that can provide and do already provide a research infrastructure across the country for non-communicable disease research, diabetes research, and great potential for further research and surveillance for this initiative. And I think SAPRIN would be really very pleased to engage further on this initiative. So thank you very much.
Thank you, Kathleen. Yeah, Prof, with your permission, we are aware of SAPRIN, obviously. Dr. Andre Rose, who is, I think, currently the acting director, is a Kofi Annan Fellow. We've had discussion even on the establishing another node in the Eastern Cape, But yeah, as we see a lot of potential, that could be a good starting point because of the infrastructure that those SAPRIN have put together. Maybe how do we now integrate those various nodes so that already there is a national database. I'm not sure how integrated the data that are collected in the various nodes are at the moment, but indeed it really presented a good opportunity to do some population-based research.
Nita, please go ahead.
Thank you very much, and thank you for an excellent presentation, Patrick. And my question actually follows with Kathy Khan, and I was going to refer to SAPRIN. So in terms of action, implementation, and being pragmatic and moving forward, it would be critical for us to, as you said, coordinate, but begin to do that. SAPRIN is actually embarking on a flagship project with Bodru and a group of other colleagues in MRC, and it would be valuable to look at not just diabetes, but also other NCDs like hypertension linked to this issue around awareness and education. So that's my first comment. And what were your thoughts about linking what you've just presented, but also to other NCDs, because our communities like to listen to the messages holistically and not silo diseases. So that's the one. The second is that from a community stakeholder engagement point of view, well done, and thank you very much for all the hard work and engagement. I believe strongly that the role of SAMRC would be then to play and continue with that role with your association and the Alliance group, but then to include, like I said, other NCDs with creating awareness on healthcare and addressing some of the issues around fragmentation so that there is outcome on wellness for the populations that are affected by this. Thank you.
Thank you very much for the kind comments and for the remark. Yes, the question of integration when it comes to the NCDs is always a question that arises. Department of Health would like us to use the approach of NCDs, but personally, even as a trained medical doctor, those conditions that we tend to group under a same acronym or same name, they are so different. There's epilepsy under NCD. There's hypertension. Yes, hypertension and diabetes tend to go hand in hand from time to time, but then there's also cancer. There's mental health. There's injuries. Are we doing justice to any of those conditions when we use the umbrella NCDs? Yes, they could be placed because of the whole of person approach, the holistic approach to see the person as one. But I think it's also debatable whether we've made success using that NCDs approach. For example, a colleague from WHO was making a remark at the summit last year, and he said, let's call them by name. Let's call them by name. And me, what I said to Ms. Janet Hunter, who was present at the summit, in a family, the kids are all different. You cannot call all your children children. There is Patrick, there is this one, there is that one, and there's other one. And the one who is at the university has needs that the one who is in primary it doesn't. And the one in primary has needs that the other one who is in maybe preschool doesn't. And yes, as a parent, it's up to you, your responsibility to handle all that. But you cannot always say when your child at the university come to share his problem with you, you say, no, go and call all your brothers. You guys must come together and tell me all your problems. No, there's a need for integration, but are we doing justice and are we being successful having that approach? I think we need to be more strategic. There are some issues awareness. We can definitely do joint diabetes and hypertension awareness campaign. But when it comes to managing diabetes, there are specific skills that are required that you might not need when you are managing epilepsy. So I think that will be just some of my reflections, and it's still an open debate in terms of how do we find the right formula when it comes to this basket of conditions.
Let's take the final comment or question from B. Simon, and then we'll close.
Hi, hi. I don't know if you guys can hear me. Thank you for your insightful presentation. I thoroughly enjoyed it from the beginning to the end. In fact, I couldn't wait for you to start because this is a topic that is very personal to me in the sense that I'm a PhD student with the Durban University of Technology, and I'm currently doing a research that focuses on gestational diabetes. So, and for me, it is something that I found very fascinating in terms of the opportunities like you've mentioned. And so my question is basically focusing on the aspect of the paternal risk factor or influence in terms of gestational diabetes, for example. I think it's an element that has not been studied to an extent or to a detail in Africa or in South Africa, because I sort of undergone a meta-analysis, which I was focusing basically in South Africa, in Africa in general. And it's interesting to find out that most of the major issues that we face, especially in South Africa or other African countries or low-income countries, is the issue of also diagnosis. And so another question that I'm also trying to pose here is that how does the South African Medical Research Council envision supporting the translation of emerging non-invasive biomarkers technologies such as like saliva, urine, breed, and wearable derived markers from discovery science into like scalable screening tools that can be implemented within resource constrained primary healthcare settings. Because most of the diagnosis or most of the potential patients are not being diagnosed because we use the screening method, especially in South Africa. So how do we go beyond that by using technologies that could allow us to actually just have like a universal diagnosis without also having to pay a lot of money? Because I know that laboratory charges are there, the use of OGTs, all of that costs a lot of money. How does the South African Medical Research Council looks into that? Are they willing to? Because I'm also looking into that maybe after my PhD, I'm trying to look into that.
Simon, I'm going to cut you off because I think you've asked about 10 questions.
Okay.
We are trying to close the discussion.
Okay.
So I'm going to ask our speaker to note your really important questions. But in the interest of time, I would like to bring this fantastic discussion to a close and to thank all of you for attending and engaging with the subject matter as you have, and to thank Dr. Ngassa Piotie for his really stimulating and challenging talk. I am fairly confident that there will be significant opportunities for collaboration between Diabetes Alliance and different units within the SAMRC. And my pledge is to support all of these aspirations. So thanks to you all, and I wish you a wonderful rest of your day. Bye. Thank you. That's fantastic. Eh? I really enjoyed that. Yeah, systematic. Okay, sure.